So with that, I just wanted to take a moment and welcome everybody to the keynote webinar today on the surgical treatment of migraine headaches. Again, our speaker is Dr. Gairan, and Dr. Totonchi will be moderating. It is my pleasure to introduce today's moderator, Dr. Ali Totonchi, who graduated top in his class from Tabriz University of Medical Sciences. He completed residencies in plastic surgery, facial cosmetic, and pediatric craniofacial surgeries. He's a board certified plastic surgeon, and he joined Metro Health Medical Center in 2010. Dr. Totonchi is also the president of the Migraine Surgery Society, so obviously an expert in the field as well, and we're very excited to have him as today's moderator. So with that, I will turn it over to you, Dr. Totonchi.
Thank you, Steve. Good morning, everybody, and thanks for the nice introduction, and thanks Global Nerve Foundation for putting this webinar together. Our speaker today is Dr. Bahman Gairan. In the plastic surgery circle, he does not need any introduction. So he has been in practice for 40 years plus, and he's the one who invented migraine surgery. I'm sure he's going to share his journey with us this morning. I know for part of his journey, I was with him. It started in 1999. With two of his patients reported to him that after cosmetic surgery, they did not have any headaches anymore. And after that, he's going to share with us that how he conducted multiple studies to get to the point that we are right now. In migraine surgery, we have a society right now called Migraine Surgery Society. As you said, Steve, we have also a nonprofit organization. We have lots of members. We have meetings that I'm hoping that we will have some collaboration with Global Nerve Foundation as well. For those of us who do migraine surgery, the joy of entering the room after surgery and see that the patient, the depressed patient that we had seen prior to surgery, has a totally different face. It is really a different feeling. So without any further explanation, I will turn everything to Dr. Gairan, and I will be happy to get your questions at the end and address them as best as we can. Thank you. Dr. Gairan.
Hey. Okay, I assume you can see this slide as well. Good morning, everybody. It is a great pleasure to be with you to share a journey that has been the most fulfilling journey for me in my 42 years of surgical career. These are my disclosures in case this is a CME credit I received. Royalties for this migraine surgery book. What I'd like to do in this presentation to talk about the importance of the topic, evidence supporting its effectiveness, meaning the effectiveness of the surgical treatment, how we detect the trigger sites, which is an integral part of the success, and very briefly talk about the surgical treatment because we obviously have mixed audience here, and I don't want to show any slides that could possibly be disturbing, and the evolution of the surgery from very complex procedures to some local anesthesia procedures under anesthesia as an outpatient operation. This topic is important because many of you know that 14.7% of the world population has migraine headaches. Almost 1 out of every 5 females suffer from migraines. 1 out of every 4 households at least has one person with migraine headaches. And it is the 3rd most common disease behind tension headaches and dental carriers. So, as Ali mentioned, the process started with 2 patients telling me about the elimination of their migraine headaches following forehead rejuvenation. One of the very important requirements for the successful medical care, surgical care is ability to listen to the patients. We learn tremendously from the patients. In fact, there's no year, no time that I don't learn from my patients. So when I heard from the first patient that her migraine headaches disappeared after a forehead rejuvenation, I thought it was a coincidence. When I heard it from the second patient, it didn't sound coincidence. And you can imagine that from this scenario, this is not a placebo effect. If the patient tells us that their headaches are gone without knowing any connection between what we did for them, what the elimination of the headaches, it really is not a placebo, which is one of the things that was claimed by some of our colleagues that were skeptical about this treatment in the beginning. But we have many other reasons to believe that this wasn't a placebo. So obviously, two patients telling us migraine headaches are gone, this is not really a science. So I'm fortunate enough to have research individuals around me all the time. And we began a study. This was a retrospective study. So we went back and reviewed 314 patients' history who had undergone forehead rejuvenation. And out of those, this was through questionnaires, out of those 314, 39 had migraine headaches prior to the surgery. 31 indicated that their headaches were either gone or improved significantly. And as you can see, there's a P power is very high, very strong at this point. And the average follow-up was 47 years. Even from the beginning, as you can see, it seemed like this wasn't a transitory improvement. And another evidence that this could not be placebo, because they didn't even know what we were investigating. So we published this article in year 2000, 23 years ago. But this was a retrospective study, and we know that retrospective studies do not carry that much power in terms of scientific evidence. So I looked into the literature to see what is the connection actually between what we are doing cosmetically and elimination of migraine headaches. Up to that point, meaning 2000, the hypothesis that was strongly advocated by our neurology colleagues that the migraine headaches are central phenomenon, start from the brain and extend to the periphery. But a neurologist, going back to 50 years previously, suggested that actually, no, migraine headaches are about the irritation of terminal branches of the trigeminal nerves and release of substance P and neurokines that ultimately result in central sensitization and systemic symptoms. So accepting that theory as a basis, at least for what I was doing, I thought about if that is the case, if the irritation of the trigeminal nerve is the reason for migraine headaches and or elimination, what is actually irritating the trigeminal nerve? And about this time, actually, we started seeing benefits of Botox in migraine headaches. And the only common grounds between the Botox and what we're doing surgically was elimination of the muscle function. At least at that point, this was the simplistic way of connecting these two benefits together. So I thought, okay, if I remove these muscles surgically from migraine headaches, can we actually help these patients? So, and I've been in the scientific field for a long time, and we don't accept anything for the face value. So we needed to prove scientifically. And there are steps that we take, as many of you know, that you've been doing studies. There are steps that you would take to prove it. So the first step in any study is to do a pilot study rather than doing a massive number of surgeries and finding that it's not working. So I teamed up with a neurologist, a headache specialist, Dr. Tarvez Tucker, who was at Case Western Reserve University at the time. We prepared questionnaires. She examined the patients, she selected the patients, and we injected the Botox. If the patients responded to the Botox, then I had a really pretty good level of confidence that I can actually help these patients surgically by eliminating the migraine headaches, by removing the frowning muscles that are paralyzed by these Botox, by the injection of Botox. So these patients underwent surgery. In this pilot study, we had 22 patients, 21 benefited from the surgery, meaning 95% of them. 10 had complete elimination, 11 had significant improvement, 1 had no response, and the average follow-up was almost a year. We followed up these patients later, for a couple of years actually. So we published this article in 2002. Obviously, the question was, if this is the answer, if surgery is the answer, why is that only 10 out of 21 patients had complete elimination? Why not everybody? And when we listened to these patients again, we discovered that actually the reason that many of these patients did not, almost half of the patients did not respond to the surgery is not because the headaches did not go away on the site that we operated. It is the headaches are arising from another site. And it occurred to me that there are obviously other trigger sites. And after that point, I don't recall seeing any article in the neurology or plastics or any literature dividing the migraine headaches to any kind of anatomical zones. And many of these patients had actually headaches in the occipital area. So we went to the anatomy lab and dissected the fresh cadavers to see what could be causing headaches in that area. In all 40 sites in 20 cadavers, the greater occipital nerve pierced the semispinalis capitis muscle to get to the skin level. And it occurred to me that, okay, if we manipulate these muscles, there's a chance that here's the picture from that dissection. This is the semispinalis capitis muscle. And this is the nerve on one side. This is the nerve on the other side. And this is a thick, long muscle. And it is clear as to how it can possibly irritate the nerve. And we designed this study to decompress this nerve, meaning greater occipital nerve, by which I'm going to describe in a minute very briefly as to what is that we do. And another patient about the same time who had undergone rhinoplasty told me after septorhinoplasty that his headaches were gone. I looked up the literature. Actually, there were some studies from Europe, from Italy. One study actually showing them a large number of patients that undergone surgery of the septum. And some of those patients actually had migraine headaches that got improved. And with all of these together, then it's designed a comprehensive study that included these 4 common trigger sites, meaning the forehead, the temple, the occipital area, and also the behind the eye headaches. And by then I was convinced that each site has an independent culprit, and we need to deal with them independently. There's no single solution that cannot address the headaches on all of these patients at the same time. And every time we have done a study, the first thing that we have looked into is the adverse effect. And obviously, many of these patients had temporary anesthesia because anesthesia along the course of the nerve that was manipulated, that was expected, goes away. And some had dryness of the nose if we did a turbinate surgery. But we found out many of these were, again, very temporary and did not have any consequences. And 3 patients had infection, and we figured out how eliminate, how reduce that potential also. But out of 89 patients that were included in the study, 82 observed at least 50% reduction in headaches, and 31 had complete elimination, and 51 had significant improvement. For our discussion purpose, we consider significant improvement, at least 50% reduction. From there on, we considered a failure. And in this study, obviously, it was a randomized study. We had a control group, 19 patients, 25 patients entered the study, but 19 completed a year follow-up. And in these patients, no one had elimination, and 3 patients had 50% reduction. We also, in this study, included 10 different parameters, validated tools from MSQ, MIDAS, and SF36 to make sure that, again, this is not a patient's assumption, and they're really objective values to consider to lend more scientific value to this study. And we also studied the cost of treatment. Their patients, there was no question of the reduction in the cost from like 7,000 to 1,000, and also reduction in the days of the work from 4 to once a month. All of these were obviously good clues that the surgery was effective, but and safe. But this was also published in the year 2005. This study also had a 5-year follow-up arm that we continued seeing these patients for 5 years, and and there was no statistically significant difference between year 1 and year 5. So again, another evidence that the results were not transitory. And when I send these articles to some of the reputable neurology journals, the criticism was that we didn't include sham surgery. Because of that, actually, some of them were rejected from the New England Journal of Medicine or journals in that level. So, okay, we designed a sham surgery, meaning after obtaining IRB from 2 separate IRB boards, we isolated and included patients who had a single site headaches consistently. For example, told us that my headaches only start from the temporary, my headaches only start from the frontal area, and we randomized those. And there were 2 neurologists, headache specialists involved in this study, including a biostatistician who designed this study. And we included 75 patients in this study, 49 in the treatment and 26 in the placebo group. In this group of patients, 41 out of 49 persons, 41 out of 49 patients benefit from the real surgery. although we had a high response to the sham surgery also, but I'll explain to you in a minute why I think that's the case. When we look at the elimination, 28 patients, 57 patients in the real group, surgery group had complete elimination. Only one had complete elimination. And the reason that I think the sham surgery group had some positive changes, the main reason is that we went down to the nerve and the vessels. At the time, we weren't really sure what the exact element of irritation is. We had some ideas, but what I believe what happened is, since we actually found the nerves and the vessels, it's quite likely that we altered the anatomy. That's why some of these patients had temporary improvement. But when you look at the elimination rate, there is no question that the surgery was more effective. Again, on this study also, we included all the tools that I mentioned earlier. And again, we looked at the adverse effects. They all were minor and temporary. So, and this, for anybody who has an open mind, this study was an absolute evidence that the surgery is effective and safe. And this article was published in 2009. But one of the studies that I'm actually the most proud of is comparing the nerves of the patients who have had migraine headaches to those who do not have migraine headaches. Again, after obtaining an IRB, biopsy the nerves of the patients who were undergoing cosmetic forehead surgery without migraine headaches, any headaches, to patients who had migraine headaches, and there were 15 in each group. And we send the specimen to the proteomics departments and neurobiology departments at Case Western Reserve University. They independently concluded that the patients with migraine headaches have deficit in myelin. As you can imagine, the nerve is in many ways vulnerable if it doesn't have myelin. So elements like pulsation of the vessels, contraction of the muscles, that ordinarily doesn't cause any irritation of the nerve on patients who have genetically disposed to have myelin deficit are going to have response and irritation of the nerves that we observe on these migraine patients. In fact, I believe the same phenomenon occurs on the whiplash injury that causes occipital migraine headaches. The nerve gets stretched because of the whiplash injury, and the myelin gets damaged, and those patients' nerves become more irritable, vulnerable, and they are not insulated properly. So we also studied to see if this surgery works on adolescent patients, and indeed we proved that it really does. And I have had many since. So our center has completed 44 studies, and as you can see, it's sort of organized and scientific manner: prospective, retrospective, prospective pilot, prospective randomized control, prospective randomized control with sham surgery, 5-year follow-up. Many other centers have done this studies, similar studies to prove that this works, including Jay Austin from Harvard, and also again many reputable centers have repeated the same studies, and over 100 articles have been published now. And besides my book that I showed you, 2 other books have been written about migraine surgery. So the first decade of this process, we devoted the time to proving the safety and efficacy. But the latter decade of 2000 was devoted to improving the results. So one of the things that we looked into to see what really causes the failure, and there was no question that the most common reason for the failure was not because surgery didn't work, it's because we failed to detect all of the trigger sites. And we have done this, I'll share a slide with you to show you that we have the many trigger sites that, where migraine headaches can arise from, can be triggered from, and we need to detect all of those trigger sites in order to serve these patients properly. The key to the success and safety of the operation is the diagnosis of migraine headaches by a neurologist. Over the last 23 years that I have doing migraine surgery, I've never operated on a patient who did not have a diagnosis of migraine headaches by a neurologist. In fact, many of the patients that I've done surgery on had been seen by many previous neurologists previously. So when the patients call to make an appointment, what we do is ask them to record a month worth of their symptoms, including where the headaches start from, how intense they are, the duration, and also the systemic symptoms, photophobia, nausea, vomiting, all of that. And then we look at all of these, and we use the constellation of symptoms, migraine headache starting point, response to the congestants. And I used to use botulinum toxin previously, and in the earliest stages is impractical to do that for the detection of the trigger sites, because now many my patients are from out of town, out of country. Nerve block, it can help, and we'll discuss many of these one by one. Ultrasound, Doppler, and the CT scan. Let's talk about these. The first, again, the first step in making the diagnosis, asking the patients to point to the site where the headaches start from. And the reason is, in this study of 1,200 patients with 2,700 who underwent 2,700 procedures, we discovered that there are actually 6 common trigger sites, and there's some really uncommon trigger sites. And I've designed an operation for each one of these that we use to help these patients. And it sounds complicated, but many of these the surgical techniques are regionally different. The technique may not be that much different. And a patient who has more than one trigger site, I'm going to ask them to show the trigger site that is most, the headaches are most intense, most common, and then ask them, do you have any headaches to start from? What is the second most common? And I also make sure that those are independent. For example, if a patient tells me, my most headaches start from my forehead, and then I get headaches in the temple area also, I'm going to ask them, can you have headaches in the temple without having the headaches in the forehead, vice versa? If the answer is yes, they can be independent, then I have 2 trigger sites. That's how we differentiate extension of one trigger site to the other side, because as you know, migraine headaches, when they are established, when the entire trigeminal tree is inflamed, the headaches are going to be within the distribution of the entire trigeminal nerve. I also ask the patient, what are the things that they do to mitigate the pain, like application of cold, heat, pressure. For example, if they say that, you know what, I take my knuckles and press in my temple, I know what the problem is. The issue is that vessel is irritating the nerve. And what they are doing is by pressing in the area, they are blocking the vessel, and I can remove that vessel so they don't have to press on it. But what's also important is to narrow it down. The patients are going to say, I get headaches here in my temple. They point to the entire temple. I'm going to ask them to be more committed and narrow it down to its fingertip in using their index finger. And the temple headache can be here.
Point to the area of the pain.
And listen, and I'm going to listen to the area.
Perfect. Just keep it there. Let it go.
So let me explain the significance of that tool. Has been an integral part of detection of the trigger site. And it is amazing how often the patients point to that spot, and I'm going to hear the pulse signal there. So and that's where we mark, and it's going to lead me to the vessel. I cannot today practice as successfully as I practice without that tool, because again, the patients can be vague sometimes. And this tool, the ultrasound Doppler, handheld ultrasound Doppler, leads me to the right place. Now, what about the nerve block? Can it help in the detection of triggers? Absolutely. If the patients have a headache, the patient has headaches at the time of visit, this tool is also very valuable if it is positive, meaning, and many of these patients, the minute you inject the site that we have marked, detected by finger point and the Doppler response, Doppler signal, they're going to tell you how much better they feel. And their face opens up, actually. Their eyes become more energetic in front of you. And does the negative nerve block mean anything? Absolutely not, in my view, although we may have some of my colleagues disagree with it. And the reason is, when the entire trigeminal tree is inflamed, you inject that particular branch, you're going to numb the area, but the entire trigeminal tree is inflamed. They're going to say, yeah, I feel numbness here, but the headache did not go away. It is too late. You will catch it in the beginning. It is going to work. It's going to help us. So as you can see, there's actually a way of us getting to the endpoint of detecting the trigger size. Neurology examination by a neurologist, 1 month diary of headaches, patients point to the site, and assuring that the sites are independent. Botulinum toxin injection in the beginning of the practice may help. If it helps, we have demonstrated that those patients are more likely to respond positively to the surgery. Nerve blocks, if the patient has pain at the time of visit. If the patient doesn't have a headache at the time of visit, a nerve block is useless. And Doppler, again, is an irreplaceable tool for us. And we also take CT if the order a CT if the patients have headaches behind the eyes. Why? I'll show you in a minute. So patients have frontal headaches. Usually the headaches start from the supraorbital area. Is late in the afternoon. They experience it late in the afternoon. Stress is a factor. You usually have strong frowning muscles. They are commonly experience eyebrow or eyelid ptosis, and the area is tender and respond to the Botox very commonly. Here, the nerves that are being irritated are the supraorbital and supratrochlear nerve by the muscle function or the vessels. And the way I inject these is just one shot far enough high, cephalad enough not to get into the levator muscle, superficial initially. As I go deeper, one injection in each side. As I go deeper, I inject the Botox 12.5 units per side. This is it. I don't inject the entire forehead for these patients. On a CAT scan, you may see a foramen where the supraorbital nerve passes through rather than a notch. I do these procedures as an outpatient operation under local with sedation or general anesthesia. We mark the eyelid, as you see there, and find the vessels and nerves and remove them. I'm not going to spend too much time on these. And this shows the foramen where the nerve passes through. We're going to release the fascia. The fascia there, as you see, it is like a carpal tunnel surgery. And if they have a tunnel, again, nerve goes through the bone tunnel, we're going to unroof that tunnel. And in a minute, you're going to see how the nerve, the size of the nerves can sometimes be different within the foramen. This is not a very common finding. Then we inject patients' own fat in the area because fat contains stem cells and helps these patients. And if the patients have combined frontal and temporal headaches, I'm going to use the endoscopic approach, meaning we use the tools that we insert under the skin and find the nerves and remove and the muscles and remove the muscles. This is the frowning muscle that I'm removing, and you can see both nerves actually in a minute, the supraorbital and supratrochlear nerve, and then we remove the vessels thoroughly. And these patients not only have no migraines, they also look better. Their lines between the eyebrows are gone and they won't be able to frown. For the isolated temporal migraine headaches, usually they have the headaches in the morning because they clench their teeth through the night, and there's a spot tenderness in the temple area. They can point to it. And here the problem is the zygomaticotemporal branch of the trigeminal nerve. Excuse me. The injection is 25 units thoroughly in the muscle. And we detach the tiny nerve that we routinely detach during the surgery. And for when patients have rhinogenic migraine headaches, usually they wake up in the middle of the night, in the morning with headaches. They can actually predict the weather. Allergies are a factor. They are hormone related, and they get more intense during the menstrual period. They have rhinorrhea, and they're often cyclic. Here, the problem is that the septum is deviated, touching the middle turbinates. They may have conchobulosa. They may have paradoxical curl of the turbinates. The beauty of CAT scan is that I can actually show the patients exactly what I'm seeing inside the nose, and they don't have to have any medical history background to be able to understand it. The occipital migraine headaches are usually in the back of the head. Many of these patients have whiplash injury or family history of migraine headaches. And obviously we need to, we were in the process of writing an article about the differentiation between occipital neuralgia and occipital migraine headache. The surgical treatment is very close, pretty much the same. And they have tenderness, the muscle is tight, and we can palpate the tenderness. Here again, as I mentioned, the nerve passes through the muscle, which is the greater occipital nerve to get to the skin level. Obviously, we can have irritation of the lesser occipital, which will be closer to the ear on these patients. So we do this surgery under anesthesia, patients lying down in the belly. And what we do is, again, like release of carpal tunnel, release the fascia, ligate the vessels that are irritating the nerve, as you see there, cauterizing the vessel, and then wrap the nerve with fatty tissues from underneath the skin and repair the incision using dissolvable sutures, and the patients go home the next day. And many of these patients have nose-related migraine headache. Not only their headaches go away, actually their airway gets better. Yes, we have lesser other sites like lesser occipital, auriculotemporal, third occipital, and we have again an operation for each one of these. This is the auriculotemporal nerve. This is the superficial temporal artery going like this, and you can see the nerve is passing over the nerve. And many of these patients, again, are going. Many of these patients undergo skull surgery using local anesthesia. They can go back to work the same day or the next day. I'm just going to make an incision, find the vessel, remove the vessel, free up the nerve. As you can see there, we're going to ligate that vessel and repair the incision, and that's the end of it. We get somewhere between 80 to 90% success rate, response rate, and many of these patients observe complete elimination. So in summary, I've shared with you a good number of articles demonstrating that the surgery is effective, how we detect the trigger sites, and very briefly discuss the surgical techniques and evolution. A huge number of these patients now undergo surgery using local anesthesia, minimal surgery, and they walk out. As I said, they go back to work the same day or the next day, and they can resume their function soon after the surgery. This is not obviously suitable for every patient, but it is suitable for a good number of patients who have migraine headaches. So I'm going to stop sharing this so we can have some time for questions and answers.
Thank you, Dr. Gairan. It was a fantastic talk. There are multiple questions actually in the from the audience. I know the first question was about the possible risks and complications of the surgery. I know you talked about this briefly, but I think it doesn't hurt if we just go over them one more time.
Whenever we manipulate the nerve, one of the most common possibilities, not that we have seen often, is the neuroma. Neuroma, though you may, all of you know, that is scarring of the nerve and can be extremely uncomfortable. But fortunately, not only I haven't seen that personally, we discussed the surgery on panel discussion. Essentially, no one has seen, or if it is extremely rare, because often we're not really cutting the nerve. We are actually removing the muscle, removing the vessel, preserve the nerve. And when we detach tiny nerves, it is there, the terminal branches, we let them retract into the muscles, and the chance of any neuroma would be minimal. In fact, in the lesser occipital area, when I detached the nerve, I implanted in the muscle to minimize that chance. Infection is a possibility, extremely rare in the head and neck area. The other possibilities include, one of the possibilities again is failure of surgery or deterioration of the headaches. Again, deterioration probably is going to be related to the neuroma, as I said, is extremely rare. Failure is usually, as I mentioned earlier, is related to not being able to detect all of the triggers. It is seldom the case that the same patient would have headaches on the same area. If that occurs, and I'm sure that I have handled the nerve properly, I'm going to inject some fat-containing stem cells in that area. With this technique, actually, we have demonstrated against science. We have done studies to show that we can help over 67% of the patients who have residual headaches of that they are sort of obscure nature, and we don't know exactly why they're getting it. Sometimes, again, scar tissues around the nerve can cause headaches. And we know that the stem cells can reduce the scar tissues. So the risks, as I said, we have it on every single study that we have done to show effectiveness. We have also looked into the risks.
Okay, the other question is about using therapeutics or some nerve barriers during the surgery. They mentioned like Exparel or Migraine or some barriers, nerve protecting barriers during the surgery. They're asking if you have used them, or do you have any experience with them?
I don't, because most of our patients the day after the surgery are going to tell me they don't have any headaches anymore. Not Exparel, but I do use, when I transect the nerve to small branches, use a small amount of Kenalog in the site to minimize the potential for neuroma or scar formation. That's the only thing that I do during the surgery. I don't do Exparel. Obviously, it has to do with the cost and surgery center having the availability in the surgery center. And we do have it. We need to, we use it, but I don't find it necessary. Again, usually especially for the smaller nerve, after the surgery, these patients don't have any headaches.
Okay, for the audience, please, if you have any questions, you can type it in the question and answer. We'll try to get through them. There was another question. Honestly, personally, I never heard this and I don't have any experience with that. The question was, have you guys used methylene blue during the surgery? And I asked them for what purpose. They mentioned methylene blue has beneficial effect in chronic neuropathic pain and sensitized nerves. I've never done this before, Dr. Kara.
Yes, I haven't done it personally, but I have seen some articles from especially China. It was Asia for the intercostal nerve during the harvesting of the rib cartilage. It may have some value, but I don't have any personal experience. That study actually was a pretty reliable scientific study to show that methylene blue may have some benefits. But again, since we don't have any continuous pain after the surgery, I haven't found the reason to do that, but we may start doing it. There seems to be some scientific support for usage of it.
Okay, the other question was about the support of societies. And again, if I'm reading this question correctly, the question is that is ASPS or other surgical societies supporting the surgery for migraine? So,
oh, absolutely. In fact, Dr. Totonchi can tell you that we are considered, actually, the Migraine Surgery Society is a sister society of ASPS, our main society, and we share the management, and we share the education programs. We're integrally connected with the main society, and the main society also wrote a white paper supporting reviewing the studies independently, and published a white paper in support of the migraine surgery.
So, very interesting question. I think it needs a lot more discussion, but we can quickly answer this question. The question says, if migraines are being caused by supersensitive or irritated nerve, how come triptans work effectively? I thought triptans mainly work on the vascular pathways, and the efficacy for migraines are well documented.
Actually, that the real reality that the triptans work is because of the vascular pathway. You recall what I said earlier. We also believe that the vessels are the main culprit in causing the headaches. And that as in search of what triptans do, shrink the vessels temporarily. What we do, remove the vessels permanently. So it is a permanent solution. Unfortunately, as you know, many triptans have side effects and patients don't tolerate it. But we essentially we're in the same track. That's why caffeine works. Caffeine reduces shrinks the vessels, and that doesn't work on everybody. None of these, and when the muscle is the culprit, it doesn't work. Triptans do not usually work that well on the patients who have rhinogenic migraine headaches because the septum is pressing on the turbinate, and triptans are not going to probably be as effective in that area. They may be effective on the extended portion of the headaches that go to when the headaches is spread to the forehead, causing the irritation of the vessels, dilatation of the vessel, or increase in blood pressure. Those are the factors that can actually be part of the triptan effect, but the main effect is shrinking the vessels, and we do that surgically.
Okay, until we receive more questions, I have a question. Considering our audience that not everybody is a surgeon here, for the person or medical neurologist who's dealing with the migraine patient, who do you recommend them to send for the surgery? Who are the best referral patients? So who do you recommend to be sent?
Actually, that is one thing that the Migraine Society can help because it can tell you who are the members. Many of the members who are actually the founding, at least the founding members are very experienced. Many of them spend time with me from day one, like Dr. Totonchi or other Dr. Austin from Mass General spent a lot of time with me. And he has been integrally involved in the symposia that we give. We also give a symposium again in conjunction with the ASPS. And the next one is going to be October, Ali, 10th or something, a whole day symposium. So you can go to the website and you can get the information about the education. You can also see the founding members' names who are intimately involved in my development of migraine surgery from day one. Dr. Totonchi was, as he said previously, and many of the individuals who are founding members have been intimately involved in the symposium, education, and even cadaver dissection. We do all of that.
We have two meetings coming up. October 14th is an online meeting, which is everybody can register for that, regardless if you are an ASPS member or not. Second one is the advanced course, which is during the ASPS meeting. So that's going to be 2 weeks after that. So during the ASPS main meeting. So we almost have like a 1 minute to finish this up. We have a hard stop at 8:30. Dr. Gairan, do you have any closing remarks? Any comment?
I think we covered everything.
Okay, thank you, everybody. Thanks for your attention. Thanks to Steve for putting this together. Have a good day, everybody. Bye.